Hello, for those tuning in. We'll just wait a couple of minutes for a few more people to come through. Okay, we'll just give it another few seconds and then we'll get started. Okay, so thank you for those who are tuning in. Welcome to the National Surgical Teaching Society's MRCS revision series. This is our second part of the anatomy SBA questions. So we'll be going through a series of questions that have been revised up by people who have fairly recently sat the exam, including myself. We'll be going through them like you would in the exam. We'll go through the question. I'll give you a few seconds. And we have a poll today. So Musa will bring up a poll. We'll give you a few seconds to answer, and then we'll go through the answer and explanation and carry on. And hopefully we won't have any technical glitches. All right, so we'll get straight into it then. So the first question we'll go through, which of the following is the correct order, medial to lateral, encountered during dissection of the femoral triangle? So A, femoral artery, femoral nerve, femoral vein, femoral canal. B, femoral canal, femoral artery, femoral vein, femoral nerve. C, Cloquet's node, femoral canal, femoral artery, femoral nerve. D, femoral canal, femoral nerve, femoral vein, femoral nerve, femoral artery. And E, lymph nodes, femoral vein, femoral artery, femoral nerve. So if we could bring up the poll, great, and give you guys a chance to, again, go through that, put your answers down. Okay. So got a few answers coming through. We'll give it a few more seconds. Give you all a chance to vote. Okay, so if we end the poll there, great. So 45% of you, I hope. Okay, so we've got 11 people who voted, not everyone, but that's okay. You can go through it on your own as well on your piece of paper. So we had some of you put E down, and those of you who did put E would be correct. Some of you put A as well, and then a couple of you put B, C, or D. E is the correct answer. So it's lymph nodes, femoral vein, artery, and then nerve. And so this question asks the order medial to lateral. So it's always just remember, just check which way or orientation they want you to think in. Inguinal canal and femoral triangle, or the femoral ring and its boundaries and its contents are incredibly common topics that will come up either within the anatomy section itself, or as part of kind of your general surgical SBAs as well. So if we remind ourselves of the anatomy and why E is the answer, you've got here the looking medial to lateral, you've got the femoral canal, and then the vein, artery, nerve. And some of you may remember navel, but just remember that way of remembering is lateral to medial. And so you want to inverse that for this question. So it would be L first, which is your lymph node, an empty space, which is essentially your femoral canal, femoral vein, artery, nerve, in that order, if you're going in that way. So you've got here, going back to the answer, nodes, vein, artery, nerve. And that's the opposite of navel, because we want, in this question, medial to lateral. Okay. So again, at the end of this session, more than happy to stick around for a few minutes for anyone who has questions or anything separate questions about the exam. So we'll go on to the next one. So I guess we could start the poll for the next question already, Musa. Thank you. Patients admitted with severe sudden onset of headaches, GCS of 13 out of 15. He's suspected to have a subarachnoid hemorrhage and an LP lumbar puncture has been requested. Which of the following is the correct order of strictures that will be passed through by the needle? A, you've got the skin, platysma, ligamentum flavum, epidural layer, arachnoid layer. B, skin, subcutaneous tissue, ligamentum flavum, interspinous ligament, arachnoid layer. You've got C, you've got skin, interspinous ligament, and ligamentum flavum, supraspinous ligament, dura mater. D, skin, supraspinous ligament, interspinous ligament, the dura mater or arachnoid. And E, skin, subcutaneous tissue, interspinous ligament, the supraspinous ligament, and then the arachnoid layer. So we've got about 8 votes so far. We'll wait a few more seconds, give you guys a chance to look through. Okay, so a couple more seconds and we can end the poll there, Musa. All right, so bit of a varied, again, between A to E, I guess. B and D seem to be the most popular, with 31% going for either B or D. So the answer to this question would be D. It would be the skin, then the supraspinous ligament, interspinous ligament, dura mater, and the arachnoid. Bit of a tricky question, because each structure that you do pass with an LP needle isn't actually in one single answer here, because they only ask for 5 things. And so, again, this type of question may come up fairly frequently with, they like to ask for certain things or certain common core procedures, what layers are passed. So for example, another example would be what layers are passed when you do a midline laparotomy incision, what layers are passed when you do a Koch's incision. Another one maybe when you do a chest drain insertion. what layers you pass. So it's worth just going through some of the core procedures and just knowing some of the structures that are passed. And so for an LP, you've got this rudimentary diagram here, but you go through skin, subcutaneous tissue, and then supraspinous ligament. And for LPs, I always try to think of, it started always with 3 Ps. And then, so that's how I try to remember that supraspinous ligament was the first of the ligaments that you pass after skin and subcutaneous tissue. And then you've got the interspinous ligament before the ligamentum flavum. And then, of course, you've got the different layers of the of going into the cord. So you've got the epidural space, the dura mater, the arachnoid space, and then you get into your subarachnoid. So it's just one to go through. Clearly, the platysma is nowhere near the back, and it's part of that thin muscle sheet in your neck. And then you've got B, C, D, and E. B and E, when you look at them, well, we start with E. Supraspinous ligament, like I said, comes before comes first out of all 3 ligaments. So when you just look at the remaining, if you look at the order, if you can remember the order of the ligament, then that will help you massively in working out. And I'm sure all of you are more commonly aware with the layers of the dura mater, subdural layer, and the arachnoid space. So I think for LPs, if you can try to remember the order of the ligaments, then it should help you get the marks. So we'll move on now and set up the next poll for this question. A 29-year-old man has presented with unilateral testicular enlargement and has a dragging sensation in his left testis. Examination reveals a firm, non-luminant mass in the body of the left testis. CT scans are requested to help stage the diagnosis. Which of the following is the primary site of lymphatic spread? So you've got those options there. Axillary lymph nodes, cervical lymph nodes, inguinal lymph nodes, para-aortic lymph nodes, and common iliac lymph nodes. So we've already got 60% who have answered. Okay. 65% of you have answered. We'll give it a few more seconds. Okay, well, let's end the poll there. So we had most of you going for D, para-aortic lymph nodes, which would be the correct answer. So those of you who got that, well done. Don't worry if you didn't. This is all for learning purposes. And the key thing to remember for this question is the blood supply. You probably will notice that from past tests, our MRCS or whatever question bank you're using, this type of question tends to come up a lot in terms of lymphatic spread. Scrotum comes up a lot, or the testes versus the scrotum comes up a lot, because it can be an anatomy question, or it can be, for example, a urological question, more specialty-based question, and depending on the approach of surgery that you use. The reason why it's D is because in the testes and lymphatic, in metastatic spread, the lymph follows essentially the blood supply. So the gonadal arteries or the testicular arteries will come directly off the aorta and supply the testes. Whereas the scrotum itself doesn't share the same blood supply, and actually lymph of the scrotum spreads to the inguinal lymph nodes. Okay, so anything related to testicular cancer, you're worried about lymphatic spread to the para-aortic lymph nodes. Okay, and that's a typical question that will come up fairly frequently. If not in the anatomy section, it may come up in a different one. And it may be to do with the incisional approach that you do in the surgery to for testicular cancers, for example. And that's why you don't do a direct scrotal excision to excise, because of the risk of seeding. Okay, so we'll move on to the next question. And we'll set up the poll for that one. Great. So an orthopedic registrar is making a posterolateral approach to the hip for a total hip replacement. Which of the following muscles is not normally divided to expose the joint capsule in this approach? So A, inferior gemellus, B, obturator externus, C, obturator internus, D, superior gemellus, and E, piriformis. Okay, about almost half of you guys have voted. Give you a bit more time for this one. Okay, give it 10 more seconds. About half of you have voted for this one. It's a bit of a tough one. Okay, so shall we end the poll there? Actually, great, thank you, Musa. So a lot of you went for piriformis. Now, this question is quite tricky. And I took a bit of time for this one to sink in as well. In this type of question, when you've got kind of piriformis, which stands out compared to the rest of the options, because you've got 2 gemelli muscles and 2 obturator muscles, it's really tempting to go for piriformis. But the actual answer here is B, it's obturator externus. And I think they quite like this question because it can trip a lot of people up. But if we look at this diagram here, you've got this group of muscles here from piriformis, the gemelli muscles, and the obturator internus and quadratus femoris. These make up the short external rotators in the hip that sit posterior. And during a posterolateral approach to the hip, which is probably one of the more common approaches, you will be dividing these short external rotators. And piriformis starts at the top. And I'm sure you are, you're all familiar with piriformis because it's an important anatomical landmark. And then you've got superior gemellus, obturator internus, inferior gemellus, quadratus femoris sitting tightly together in that order. Obturator externus actually sits, as you can see, on this side. It comes more anteriorly, covers the outer surface of the anterior wall of the pelvis, and it actually makes up the medial compartment of the thigh. So that's the odd one out. And I just learned this as an exception to the rule. I try to think of it to myself, that obturator externus, so it's X, leave it out. So you've got 2 gemellus muscles and 1 obturator piriformis. Sometimes they may throw in quadratus femoris to also be aware of, but try to know these short external rotators of the hip, because this type of question may well come up. Okay. Let's go on to the next one and start the poll. Thank you. So a 56-year-old gentleman presents with a swelling at the back of his knee. It's becoming increasingly larger in size and is causing restriction in his range of movement in the knee. In the clinic, you examine the popliteal fossa. Which of the following structures is the superolateral border of that popliteal fossa? So you've got A, sartorius, B, medial head of gastroc, C, lateral head of gastroc, D, tendons of biceps femoris, E, tendons of semimembranosus. Okay. So almost 70% of you have voted so far. Give you a few more seconds for anybody else who wants to vote. Okay, so let's end the poll there. Great, thank you. So the majority of you put tendons of biceps femoris, D, which is the correct answer. Okay. So well done. So for this question, it's clearly not going to be either of the gastrocnemius muscles because they're in the calf, the lower leg, and so that's going to be one of the inferior medial or lateral aspects of the border. And it's easy because it tells you the anatomical name is the medial head or the lateral head. Okay. Now, sartorius does not make up part of the popliteal fossa. It's either the biceps femoris or semimembranosus or semitendinosus because they almost insert nearly onto the same aspect. So if you look at this diagram here, you've got biceps femoris coming down with the gastrocnemius on the lateral head. So the answer here would be biceps femoris. And then medially, you've got semimembranosus. And this white sheet here, or well, it's not really a sheet, it's a tight rope-like thing. That's the tendon of semitendinosus, the other muscle of the hamstrings. So biceps femoris is lateral, semimembranosus medial. And I tried to remember it as semimembranosus, M for medial, and biceps femoris lateral. So another question with borders, something they quite like. So moving on to the next question with the poll. A 50-year-old man presents following penetrating injuries to his left upper limb. On examination, despite no vascular injury, his finger extension is severely limited. Sensory function remains intact. Which nerve is most likely to have damaged? So you've got anterior interosseous nerve, medial antebrachial cutaneous nerve, muscular cutaneous nerve, posterior interosseous nerve, or the radial nerve. Okay, so almost 2/3 of you have voted. Pretty good. Okay, but we'll stop it there. And yeah, again, more than half of you of that voted went for posterior interosseous nerve, which is the correct answer in this case. So, okay, just move that out the way again. So you got a few things here going on. You got penetrating injury to his left arm. There's no vascular injury. Now, the key bit here is that in the question, only motor function is damaged and sensory function is intact. Okay, and we go through. So we know that the B is a cutaneous nerve and it's purely sensory. All right. we know that D, posterior interosseous nerve, is a continuation of the big radial nerve that comes off. And radial nerve is mixed sensory and motor function, whereas remember that posterior interosseous nerve is purely motor. Okay, so as it comes down the forearm, it only has a motor function, and it supplies essentially the extensor muscles in the forearm. Okay, and well, apart from extensor carpi radialis longus and extensor carpi radialis brevis, and essentially damage to PIN will produce finger drop and poor wrist extension. And you can see from this diagram, the level at which you damage the radial nerve will give different symptoms. So for example, PIN is more of a forearm nerve continuation of the radial nerve, and it's only motor. So any question that has weakness in extension, you'll know that it has to be something in the extensor compartment, which is supplied majority by the radial nerve. But PIN is the division of the continuation and branch of the radial nerve that supplies motor to the forearm. Okay, whereas the big radial nerve more proximally has sensory innervation, as well as it's a big nerve supplying the triceps as well. Okay, and then again, we know some of the other options here. Muscular cutaneous nerve is a flexor and supinator, and a anterior interosseous nerve branch of the median nerve. So they would affect flexor compartments. Okay, so you can work through, if you could probably whittle it down to between D and E here, and if you can try to remember that PIN is pure motor, whereas radial nerve isn't, and that would get you the marks here. So let's move on to this question and initiate the poll. Which of the following nerves does not arise from the posterior cord of the brachial plexus? A, upper subscapular nerve, B, long thoracic, C, thoracodorsal nerve, D, axillary nerve, or E, radial nerve. Okay, I'll give you a few more seconds, but more than half of you are voting now. Okay, so we'll end there. Great, so 60% of you that voted went for long thoracic nerve, which is the answer in this case. So well done. Brachial plexus, again, really commonly tested part of the anatomy. They love it in anatomy questions. They'll ask sometimes, to be fair, although a lot of the questions, and I mentioned on Monday that they tend to make the stem of the question really long and a lot of text to read through, and that's part of what contributes to your the pressure of time. But so they do also put in just these simple one-line questions, and we can look at the brachial plexus diagram here, and just you can draw out the more simplified version and know the main branches, because also we'll cover this when we start doing specialty-based questions. But for example, upper limb orthopedics, they like questions about stretching the brachial nerve and giving things like Erb's palsy, and we can cover that another time. But as you can see here, if you look at the roots, that's where long thoracic nerve comes off from C5, C6, C7, and it comes off before the brachial plexus starts dividing into its trunks, divisions, and cords. So I'm sure, if it was asking about, the lateral chords, medial chords, posterior chords, you'd be able to deduce, where does the axillary nerve come off? Oh, the lateral cord, we know, gives off muscular cutaneous nerve, medial cord contributing a lot to the ulnar nerve. But try to remember that long thoracic nerve is part of the brachial plexus, but comes off, the first thing it comes off at the roots, okay? And I would say for this level, of all of these different types of nerves, the ones to really remember, other than your main musculocutaneous, axillary, radial, median, and ulnar nerve, is knowing the long thoracic nerve comes off the roots. I would know that the dorsal scapular nerve also comes off the root. Okay. And then at least know from the posterior cord, the branches that come off there, thoracodorsal nerve, particularly, because that is going to be innervating your latissimus dorsi. And sometimes they may ask about that. And then also the other nerves coming off the posterior cord. So you've got the upper subscapular nerve and the lower subscapular nerve. And we'll go through them later. And don't worry about nerve to subclavius, but also know suprascapular nerve also comes off on the lateral aspect at the trunk. Okay. So it is quite a lot, but again, I know this session isn't to try to teach anatomy, but try to aware. And we've got another example later on where I'll explain why it's important to know some of those other smaller nerves. So we'll go on now to this question. If we start the poll. A 30-year-old gentleman presents with numbness over his left foot. He has been experiencing this particularly over the dorsum of the first web space on his foot. Which of the following is true regarding nerve supply to the foot and lower leg? So which of these is true? A, the common peroneal nerve supplies sensation to the first dorsal web space. B, the sural nerve runs on the posterior medial aspect of the leg and supplies the medial aspect of the foot. The superficial peroneal nerve runs in the anterior compartment of the leg and innervates peroneus tertius and sensation to the dorsum of the foot. D, superficial peroneal nerve runs in the anterior compartment of the leg and innervates tibialis anterior and sensation to the dorsum of the foot. And then E, the deep peroneal nerve supplies sensation to the first dorsal web space and innervates tibialis anterior. Okay, I'll give you it's a bit more wordy, this one, so I'll give you a few more seconds. Almost half of you have already voted. Okay, so we can stop it there. Thank you very much. So majority of you voted right. The answer to this question is E. The deep peroneal nerve supplies sensation to the first dorsal web space and innervates tibialis anterior. So just remember the nerves that travel in which compartment, and then knowing the difference between deep and superficial peroneal nerve in terms of its sensory function. So for this question, just working through the options, okay, oops, sorry. Working through the options here. The sural nerve says runs in the posterior medial aspect. However, the sural nerve runs in the posterior lateral aspect, okay? And so B isn't correct. A, the common peroneal nerve supplies sensation to the first dorsal web space. Well, common peroneal nerve is a big bundle of nerves that splits into the deep and superficial peroneal nerve. And so That can't be correct. Okay. C and D both say that the superficial peroneal nerve runs in the anterior compartment of the leg. Now, regardless of whether and what those options end with, that can't be correct because the superficial peroneal nerve runs in the lateral compartment of the leg, of the lower leg, okay? And it's the deep peroneal nerve that runs in the anterior compartment of the leg. And so that makes E, by, ruling the others out, the correct option. And you can see from this diagram here, in this web space, in the blue between, you've got that is the nerve that's supplied by the deep peroneal nerve, and the superficial peroneal nerve coming down here in yellow supplies the rest of the dorsum of the foot. Okay, saphenous nerves supplies the medial aspect, and more posterolaterally you'll have the sural nerve. Okay, so deep peroneal nerve. And also clearly within that answer, because it's traveling in the anterior compartment, it's going to be innervating tibialis anterior, because that travels down the anterior aspect. And essentially you'll have the extensors that are extensors of the lower leg that are supplied by the deep peroneal nerve. So it could have been extensor hallucis longus, extensor digitorum longus would also be innervated by deep peroneal nerve. Okay. And before we move on, just remember, tibial nerve runs down from the sciatic nerve. Tibial nerve runs straight down through the posterior compartment of the lower leg. And it's the superficial peroneal nerve that runs in the lateral aspect, innervating peroneus brevis and longus tendons and muscles. And then you've got the deep peroneal nerve then that travels in the anterior compartment. Okay. And another thing is, know that peroneus tertius, the muscle in C, although despite its name, it doesn't run in the lateral compartment. It's an odd one out, so it runs in the anterior compartment. Okay. So we'll move on to this question here. Thank you very much. 40-year-old man was brought into the emergency department with a gunshot injury to the upper right thigh. On examination, the wound lies 4 centimeters below the inguinal ligament. The vascular status of the limb is normal. There is numbness over the anterior thigh and medial aspect of the leg. Although he's able to flex the hip, he's unable to extend the knee on the affected side. The knee jerk is diminished, but the ankle jerk is preserved. Which nerve is likely to be affected? So A, sciatic, B, tibial, C, saphenous, D, common peroneal, E, femoral nerve. Okay, great. So we'll stop the poll there. And it was an overwhelming majority for E, which is, of course, the correct answer. It's the femoral nerve. So you can go through kind of what's affected here and, look through. And clearly, most of these things will be affected by the femoral nerve. So you've got, first of all, remember that, femoral nerve comes off L2 to 4. And it will pass under the inguinal ligament on the medial side and enter the femoral triangle, like we saw earlier. Now, when that nerve is damaged, you will have both motor and sensory function affected. Okay, so femoral nerve, remember, it innervates iliopsoas, which helps in hip flexion. Quadriceps also help hip flexion, but iliopsoas will help hip flexion. And although he is able to flex the hip, okay, he's unable to extend the knee. And that's the big clue that it's going to be the femoral nerve really here, isn't it? Because we know that femoral nerve innervates the quadriceps, that's going to extend the knee. Okay. So we know that the sciatic nerve doesn't affect the knee extension, tibial nerve again, extension of sciatic, and it's not going to affect the quadriceps. Saphenous nerve doesn't have a motor function. And again, like we saw in the previous question, it's a sensory nerve medially. Common peroneal nerve, again, comes off at the knee, wrapping round the lateral epicondyle and running down, splitting into superficial and deep peroneal nerves. And so it's not going to affect the quadriceps. And so femoral nerve, you should be able to work through this, which you all did. So it's a nice one to get, this one. Okay, so moving on to the next question. Which of the following arteries does not arise from the axillary artery? So which isn't a branch that comes off the axillary artery? You got A, superior thoracic, B, lateral thoracic, C, thoracoacromial artery, D, costocervical trunk, and E, subscapular artery. I think on the, oh, thank you, Moose. Yeah, let us know in the chat, Marwa, if you can't see the poll. Hopefully it's coming up for this question now. Okay, so I'll just give you a few more seconds for this one. Okay. Okay, so we'll end the poll there, Musa. Okay. And I hope it's resolved for you, Marwa. Let us know if it hasn't. But yeah, most of you got this again. Correct. It's D costocervical trunk. Okay. So the costocervical trunk does not arise from the axillary artery because it comes off the subclavian artery. Okay, so this schematic shows you the axillary artery itself, and axillary artery you can break it down into three parts. First part gives off one artery, the second two, and the third three, going from top to bottom. The first will be the superior thoracic artery coming down, supplying part of the thoracic wall cavity. You've got the second part, which has two branches. You've got thoracoacromial and lateral thoracic artery. And then lastly, you've got subscapular artery and the anterior and posterior circumflex divisions of the humeral artery. And so the odd one out here is the costocervical trunk. And we know because, you know, that it's we know that comes off the subclavian artery. Okay, so moving on. Bring up the next poll. 19-year-old male is brought into the emergency department. Another stab wound. And, it's to his right arm. The penetrating wound is located in the cubital fossa. There is concern about the neurovascular status of the patient's arm. What is true of the following statements? The brachial artery lies lateral to the biceps tendon. The median cubital vein lies deep to the brachial artery. C, pronator teres makes up the lateral border of the cubital fossa. Median nerve lies immediately lateral to the bicipital aponeurosis. And E, the radial nerve lies in the lateral aspect of the cubital fossa. Okay, give you a little bit of time for this one. Okay, a few more seconds. Okay, so we'll stop it there, just in the interest of time. Great. So a bit of a mixed response on this one. It's quite tricky, and it's again one of those questions that's really essentially knowing the order in which things come up and lie within a cavity. So, you know, antecubital fossa, popliteal fossa more about, you know, superficial to deep and how the structures lie, and antecubital fossa, no, either medial or laterally, depending on how you want to learn it, know the structures that pass through. And for this question, the answer is E. It's the radial nerve that lies in the lateral aspect of the cubital fossa. Okay, so although the radial nerve, you would think, because it essentially innervates the triceps and the posterior aspect of the arm, it does hook around and passes through the lateral aspect of the cubital fossa. And if we look at this one, you can see, again, appreciate the boundaries of the cubital fossa, which is a triangular shape, by an imaginary line between the epicondyles and the elbow space. And then you've got pronator teres on the medial border, and then brachioradialis laterally. Okay, and so looking on here, the medial nerve runs medially, and that's quite nice to remember because it's on the medial aspect of the fossa. Okay, you've got the median nerve coming down. Immediately lateral next is always the brachial artery. Okay, and then you'll have the bicep. It's not on this diagram, apologies for this, but then you'll have your bicipital tendon coming down with the radial nerve more towards the lateral aspect of that of the anterior antebrachial fossa. So you've got E, which is the correct answer here because radial nerve is on the lateral aspect. A isn't, because brachial artery, as we saw in that image, lies medial to the biceps tendon. The median cubital vein lies deep to the brachial artery. Well, the artery is deeper than the vein, isn't it? And we know that. Pronator teres makes up the lateral border. As we saw with the boundaries here, pronator teres makes up the medial border. And then option D was median nerve lies immediately lateral to the bicipital aponeurosis, but actually it has a very close association with the brachial artery and lies immediately medial to the brachial artery. Okay, so another one for remembering the order of things. So if you always remember, brachial artery and median nerve go together, but median nerve is the most medial structure and radial nerve is the most lateral structure. And just remember those 4 key components within the antebrachial fossa. Hopefully that will be okay. So the next question, you got a 23-year-old lady presented overnight following a crush injury into her lower left leg. Her pain was excruciating, requiring a large amount of analgesia. Examination revealed an erythematous swollen leg that is tense on palpation. You got increased pain elicited upon passive extension of the foot and great toe. In which of the following compartments is raised pressure likely to have developed? Okay, so A, anterior, B, lateral, C, deep posterior, D, superficial posterior, or E, popliteal fossa. Okay, I'll give you a little bit more because it can be tricky, this one. So almost half of you have voted actually now. So 5 more seconds. Okay, so we'll end that one there. Thank you, Musa. So we've got mixed bag. So some of you said anterior. So a few of you also said deep posterior. Okay, so remember with compartment syndrome, a key thing, either in anatomy questions such as this one, where it's mentioned passive extension or a passive certain movement. So in this example, it's extension of the foot and great toe, or if it was an orthopedic question and it's compartment syndrome, it will have, significant or severe or intractable pain, particularly on passive stretch of a particular muscle. As long as you work out which compartment of the leg that muscle lies in, responsible for the movement, then you can work out the answer. So for this, the answer is A, it's anterior. Okay. Now remember, the key bit here, like I said, is passive extension of the foot and great toe. Okay. So if you've got extension of the great toe moving up, as well as extension of the foot, which is essentially the same as dorsiflexion rather than plantar flexion. Okay, so you've got the foot dorsiflexed and then extending the great toe. That's contributed by the anterior compartment, because remember, the anterior contains the extensor muscles, the extensor hallucis longus, that is responsible for extending that great toe, as well as you've got, well, a combination of muscles that contribute to dorsiflexion, but a big one will be extensor digitorum longus, okay, peroneus tertius, but the big strong one is tibialis anterior that aids dorsiflexion. So anterior compartment is the correct answer for this one, okay. Lateral, obviously it would be on passive eversion of the foot, okay, and then, or you've got CD, so the posterior compartments, it would be gastrocnemius, and then deeper down you've got the flexors. But again, because we explained that it's the extension of the foot and great toe, those are the movements. Work out what muscles contribute to those muscles, and then where do those compartments lie. Okay, so next question. We've got a 69-year-old man who undergoes carpal tunnel decompression. He complains of difficulty after the operation on moving his thumb. Which nerve is likely to have been injured to have caused this? So A, anterior interosseous branch of the median nerve. B, recurrent branch of the median nerve. C, palmar-cutaneous branch of the median nerve. D, superficial branch of the ulnar nerve. And E, deep branch of the ulnar nerve. Okay, give you about 10 more seconds. Okay, so we'll end it there. So quite a lot of you said the anterior interosseous branch of the median nerve. Okay, and so someone also answered recurrent branch of the median nerve. And the answer to this question is B, it's the recurrent branch of the median nerve. Okay, now in carpal tunnel syndrome, the nerve that innervates the thenar muscles, that gets compressed to lead to thenar wasting, that is a sign of carpal tunnel, is the recurrent branch of the median nerve. The recurrent branch comes off just distal to that transverse ligament, and when that's because it's in the field of view when you operate on a carpal tunnel, that can potentially be injured during the operation. We know D and E can't really be, because the ulnar nerve travels in the Guyon's canal, and it wouldn't necessarily be affected. Palmar-cutaneous gives you a hint that it will be sensory, so it wouldn't necessarily lead to a motor deficit. So it leaves you with B or A, and B, recurrent branch. If you know that innervates the thenar muscles, then you should get hopefully next time we'll get the answer correct. The anterior interosseous nerve comes off higher up in the arm to supply the deep muscles of the anterior forearm. Okay, so recurrent branch comes off at the wrist and supplies thenar. Anterior interosseous comes up further up and supplies the deep flexors of the arm, such as your flexor digitorum profundus. So we'll go on to the next question. The patient presents to the emergency department. Oh, sorry, that's not the... Okay, so the poll is showing a different question. So I will try to... Okay, so on the poll, the answers are the same, but just ignore the stem. But this is the stem of the question. A patient presents to the emergency department with left-sided facial weakness, a loss of sensation to anterior 2/3 of the tongue, and hyperacusis. There is no vestibular dysfunction, and tear production in both eyes are normal. Which of the following regions would a lesion to the facial nerve result in symptoms that this patient has? So the left stylomastoid foramen, the left facial canal, left geniculate ganglion, the left cerebellopontine angle, or E, the left parotid gland. Okay, so just give you a little bit more. Okay, so we'll leave it there. It's a tough question, this one. The answer to this one is the, is the left facial canal. And I hated revising this one, but knowing, the anatomy of the facial nerve and knowing where the branches come off to innervate various structures will help you try to just essentially work this out. I know this is quite a convoluted one to try to go through because we are running out a little bit of time. The facial nerve comes out, obviously coming off from the brainstem, and it will come through. And a lot of you mentioned the left stylomastoid foramen. Now, the main reason why that wouldn't be the case for this one, because still within the left stylomastoid foramen, you would potentially get vestibular dysfunction if that were the case. Now, in this question here, so trying to just go through it systematically, the facial nerve, obviously it's primarily a motor, okay, and it supplies the muscles of facial expression, which this patient had. Okay, so that's the first thing. Now it had other deficits as well, and so it can't have essentially been a deficit at the left parotid gland, okay, because if it's a damage there, that's almost towards the terminal branch. The parotid gland is where the terminal branches of the facial nerve comes out, and so you would only really get almost like a Bell's palsy picture if that were the case, with left-sided lower motor neuron lesion affecting left-sided facial muscles. Okay, so we can rule left parotid gland out. What else? So D, the left cerebellopontine angle. Now that's really proximal in its in the facial nerve, and so right at that angle, if there was damage or disruption to the facial nerve, you'd essentially get all of the functions of the facial nerve being affected. And because, as we can see from the stem, it wasn't, then, we can say that that's too proximal. Okay, and it leaves you with A, B, and C. Now, the geniculate ganglion, okay, that you can see from the diagram there over here. I don't know if you can see my cursor, but that's where the geniculate ganglion is, and it produces nerve branches to the lacrimal gland as well as the parotid gland. And so if the tear production function, as it is in this question, was normal, then we know that the lesion isn't in the left geniculate ganglion. Okay, and also a lesion purely at the left geniculate ganglion, as it's already come off here, you wouldn't get the constellation of symptoms within this question, because tear production is normal in both eyes. Okay, that leaves you with A and B, and the left stylomastoid, as I said earlier, is a bit more proximal to the facial canal itself, and you have nerve to the stapedius, which would give hyperacusis, but also has input on the vestibular cochlear nerve that runs very close to it, and so you may also get the vestibular system being affected too, but this patient doesn't. So I found this type of question really difficult. I just tried to remember the target organs of the facial nerve, knowing that the geniculate goes to the lacrimal and the parotid gland is essentially the site of terminal branches, and then knowing where the stylomastoid foramen with input of the facial nerve to the stapedius and the vestibular system. Okay, so sorry about that convoluted long explanation. Now, I know it's 8 o'clock and it's been an hour. I'm more than happy to crack on and finish the set of questions if you guys are. Obviously, if you need to go, feel free, and this recording will be available. Okay, so should we go to the next one? A 48-year-old lady presents with stridor and cyanosis. The patient has bilateral vocal cord paralysis and an open tracheostomy is required. Which of the following structures are not encountered during this procedure? Another question about going through layers, really, isn't it? Okay, guys, I'll give you about 10 more seconds. Okay, so we'll step there. Very varied set of responses. Okay, so it's stretched all the way across the different options. The answer to this one is it would be D, the superior thyroid artery. Okay, now obviously in tracheostomy it will be in the midline. Okay, the layers that you go through, so it's the skin, you've got cutaneous tissue, the deep investing layer of fascia, the platysma, sorry, and then the deep investing layer. Okay, and then you've got strap muscles that will lead to the thyroid isthmus, and then you're onto the tracheal rings. Okay, and it's the superior thyroid artery that comes off, and from this diagram you can see that, first of all, superior thyroid artery is because it comes off laterally on both sides. It's less likely to be hitting your approach on a midline incision. Okay, and also it comes off quite high, with it coming inferiorly down, whereas the rest of the structures, platysma is a thin sheet of muscle that comes down the neck and that you will always go through. The deep investing layer of fascia will enclose all the structures of the neck, and it's probably the most outermost fascial layer. And then within that, when you study the different types of compartments within the neck, you'll have, for example, your carotid sheath layer, you've got prevertebral, pretracheal fascia as well. Your strap muscles will be having to be incised and divided and retracted to gain access to this midline area. And then as you can see here, you'll be going through the thyroid isthmus as well, okay, down onto the second or third rings of the trachea, okay? So this type of question, superior thyroid, or if the question asks, you know, if the same for inferior thyroid arteries, just remember those thyroid arteries are usually more lateral coming through, and so you're able to you know, stay clear of those on your incision. So the next one, and then an elective patient is to undergo treatment for symptomatic varicose veins. She's been consented for a saphenopoppliteal ligation and stripping of the short saphenous vein. In the consenting process, which of the following nerve is at risk of injury as part of the procedure? So you've got saphenous nerve, sural nerve, the common or superficial perineal nerves, or the deep perineal nerve. So this patient is going for a stripping of the short saphenous vein. Okay, I'll give you about 10 more seconds for this one. Okay, so stop it there. Okay, so 40% of you said, or 40% of you that answered said sural nerve, and that would be correct. Okay, so the answer to this is B, the sural nerve. Okay, now this is, I put this in this set of questions just because it's a good one to just remember, as it may or may not come up. And knowing the relationship between the short saphenous vein and the sural nerve that are quite close together, as you can see from this diagram. Okay, so the sural nerve comes laterally, as we were talking about previously, innervating that cutaneous, the skin of the lateral aspect of the lower leg. And then the short saphenous vein also begins on the lateral aspect of the lower leg and travels up, ending in the popliteal fossa. So the sural nerve and the short saphenous go together. Now, the saphenous nerve, that's more in close relationship with the great saphenous vein. Okay, so the great saphenous vein comes more posterior medially, and the saphenous nerve is a medial. And we saw from before when we were looking at the sensation innervation of the foot, the saphenous nerve, innervates the medial aspect of the foot. Okay, so if you can try to remember those two, that could help you in some of these types of questions. Okay, and in this, the perineal nerves aren't actually, you know, they're either in the anterior compartment. Common perineal nerve is way too high, and that will split into the superficial perineal nerve and deep perineal nerve. Deep perineal, as I said before, is in the anterior compartment. Superficial perineal nerve is too lateral. It's in the lateral, completely in the lateral aspect, too deep compared to the venous system. Okay, so you've got the next question. 20-year-old male is brought to the emergency department after having sustained blunt trauma to the chest. On examination, he's tachypneic with a respiratory rate of 40, heart rate of 120, and a systolic blood pressure of 70. He has bruising over his right lower ribs, tracheal deviation to the left with right-sided hyperresonance to percussion, decreased breath sounds. Needle decompression is performed at the level of the second intercostal space. The manubriosternal junction is palpated to locate the area. Which of the following anatomical structures does not lie at that junction? Okay. Bit wordy stem. You got between T4-5 vertebral bodies, bifurcation of the trachea, entry of a zygous vein into the superior vena cava, the beginning and end of the aortic arch, and the hemiazygous vein passing from left to right to join the that should be azygous vein, not zygous. All right, so almost a quarter of you have already answered this one. Okay, half of you, let's do 5 more seconds. Okay, so we'll end it there. Great. So majority of you put E, which is the right answer for this question. So this is obviously another key anatomical landmark. And like we were talking about the transpyloric pain on the last session, the angle of Louis or the manubriosternal junction is another landmark that you should be really familiar with to know the structures that line up in that area. And, you know, to be fair, for this question, even without knowing every structure that passes through that line, we know that we should hopefully know that the hemiazygous vein is passing on this, it says passing from left to right to join the azygous vein. Now, the hemiazygous vein drains the right posterior thorax, the majority of that. And so it wouldn't pass left to right. If anything, it would be right to left. Okay. So that's why it's not E. Okay. But also because the rest of the structures are part of, are structures that line up within the angle of Louis. And so if you get familiar with that structure, then you should be able to sift through that question nicely. Okay, so a few more questions to go. Sorry, Ahmed, let me just go to the end slide. If you want to just get that QR code for the feedback. Oh, okay, brilliant. Thank you, Musa. You've done that. So we'll just go back to the question. We're almost done, guys. So a 67-year-old lady is to undergo mastectomy and axillary node clearance for a central invasive breast tumor. She'll be having level 1 and level 2 nodes excised during the procedure. Which of the following structures best defines the level of axillary clearance? So axillary artery, axillary vein, pec minor, pec major, or teres major. Okay. So 5 more seconds. I think most of you have got this one as well. Okay, so let's end it there. Great. So majority of you said pectoralis minor, C, which is, of course, the correct answer. Yeah, pec minor is a structure that essentially you take different levels of lymph nodes within the axilla. You've got level 1 that is inferior to the the inferolateral border of the pec minor. You've got level 2, which lies directly posterior to pectoralis minor, and then level 3, which is essentially superior to or superomedial to pectoralis minor. Okay, so pectoralis minor for that question. This is probably one that's also repeated quite a lot within question banks. So next one, what dermatome level does the umbilicus lie? We'll give you a few seconds for this one. So T8, T10, T12, L1, L2. Okay, so we'll end it there. And like most of you have said, the answer is B, is T10 for this one. Okay, so dermatomes, knowing dermatomes and myotomes is really important. And it's one of those things that, you know, you just potentially could forget or muddle up sometimes, particularly the myotomes, more so than dermatomes. And so just closer, as you get closer to the exam, just try to refresh yourself with these, because they seem to come up quite a few times. This question came up in my exam exactly like this. It was just literally one line was the answer. And if you know your dermatomes, it's just bang, quick, 2 seconds and move on. And it's the same with kind of, you know, knowing your reflexes and what nerves, what spinal roots contribute to them. Some of the things that they just throw in there. Okay, so more towards a simple end, but again, comes up. So let's do one more question. So which one of the following tendons are contained in the second compartment of the extensor retinaculum? Okay, so extensor digiti minimi, extensor carpi ulnaris, extensor carpi radialis longus and brevis, abductor pollicis longus and extensor pollicis brevis, E, extensor digitorum communis. Okay. Give you about 10 more seconds. Okay, let's finish it there. So again, yeah, most of you went for C, extensor carpi radialis longus and brevis, and that is the correct answer. And you can see from this diagram, it shows the extensor compartments within there. So compartment 1 makes up part of your scaphoid triangle. My mind has just gone blank for that space. Anyone wants to put it in the chat? You've got that border there, extensor pollicis brevis and abductor pollicis longus. Extensor compartment 2, which this question was asking about, is your extensor carpi radialis brevis and longus. Yes, thank you, Sanjana. It's the anatomical snuff box. So you've got, and this one, I guess people have different ways of remembering it. I didn't really have a specific mnemonic or anything to do that, but I felt like as long as I knew compartment 1 to 3, the rest kind of fell into place. And just knowing the compartment 1 is part of the anatomical stuff box, so you check those 2 off, and then like in the anatomy of the flexor compartment in the anterior forearm, where you've got flexor carpi radialis and flexor carpi ulnaris, sandwiching in between. I try to remember those 2 as the borders of 2 and 6, and then the 3 in between. Yeah, I'm sure everyone will have their own way of remembering this, but it's one of those things that can come up, and it's, you know it or you don't. But if you do, and you can find a good way of remembering for yourself, it'll be an easy mark. Okay, so knowing this, and then know what structures pass through your flexor retinaculum too. Okay, or the carpal tunnel, should we say. So we'll end it there. Sorry if it felt slightly rushed towards the end. Just wanted to cover as much questions as I could. I hope, again, you found it quite useful. Like Monday, this is the QR code. If you guys don't mind scanning this and just giving us feedback, so that we can try to keep amending and adjusting our sessions to the benefit of you guys. The next session will be on Monday, so we'll come around pretty quickly. On the 11th, which is definitely a Monday, because I think on the last session I said the 7th and I meant the 8th, so apologies for anyone who got that mixed up. And we're expecting it yesterday. So on Monday evening, we'll be doing physiology. So we'll do next week 2 sessions, Monday and Thursday. We'll do physiology, 2 sessions. So I hope, again, you found it useful. The recordings will be available. Does anyone have any questions in the chat? Any general questions they had about the exam? I'd be happy to answer anything as much as I could. Otherwise, you know, for those who attended both sessions, or for those of you this evening who just attended this session, anatomy might seem like probably one of the most daunting aspects of the exam, but actually, because, you know, you probably will be spending a lot of time just drilling yourselves with question banks as well as revising, you'll do it so much that when it comes to the exam, you'll find that you're answering most of these anatomy questions quite well and thoroughly. And like I said, if you can cover past test and EMRCS question banks, it'll be a really good way. Even if you can do it twice over, that'll be great, and you'll be in a good place to tackle this exam, because that's what I did and it helped massively. There's another resource called Pass the MRCS. I don't know if many of you use it, and that has a Part A resource. I only use Pass the MRCS for Part B, but because again, it's a lot of money to be putting into lots of different types of resources. But just for those FYI, if you haven't got Pass the MRCS, and again, I didn't use Pass the MRCS for Part A, what I didn't know when I did use it for Part B is that you get a free access to Ackland's Anatomy. And, you know, Ackland's Anatomy has amazing videos to just go through different parts of the anatomy, you know, really concise videos, straight to the point, and short videos as well. So it's not too, you know, overload of information. So if anyone was thinking, but, you know, about Pass the MRCS, although I don't know what their Part A question banks are like, yeah, the fact that they give you a free access to Ackland's Anatomy is a really good plus for that resource. Okay. Anyway, well, thank you very much for attending the session. Obviously, I can't, because of the webinar function of Zoom, I can't see each and every one who has tuned in. But I hope the polls made it a lot more interactive. And so we hope to see hope to see you all back on Monday for some physiology. So enjoy your weekends. Thank you very much.